This is an MS Views Now program. This is solely sponsored by MS Views and News. And tonight, though, we have Dr. Mitzi Williams, and Dr. Mitzi Williams is from the great location of Atlanta, Georgia, a hopping town. If you've never been there, it's a great place to go. So much to do. And Dr. Williams tonight is speaking about multiple sclerosis in the Black community, and what are the ups and downs of what they get with healthcare, and how they can see their neurologist and speak more to their neurologists, whoever that might be. And so you could see it all in front of me, and I'm just going to let Dr. Williams take it away. And take it away.
Awesome. Thank you so much, Stuart. And thank you, MS Views and News, for sponsoring this program talking about MS in the Black community. I know we just finished Black History Month, but we are in MS Awareness Month. And so there's a lot to be talked about. I really wanted to focus this program primarily on empowerment, right? So how can you prepare for your doctor's visits? How can you get the most out of it? And what kind of things can you be doing to help yourself? I'll talk a little bit about some of the data focused on MS in the Black community, and then we'll go from there. All right, so let's get the party started. All right, so when we think about MS in the Black community, I always want to take a step back and just make sure that we're all on the same page about what is MS, right? MS is many different things to many people, hence this graphic of it's supposed to be a tree, but I couldn't get the whole thing on the slide. But it's a tree with a bunch of different words that really kind of just describe little pieces of what multiple sclerosis is. If we think about a scientific definition, we know that MS, or believe that MS is an autoimmune disease, meaning the immune system, the part of the body that normally attacks viruses and bacteria, gets confused and attacks a good part of the body. The myelin, or coating of the nerves in the central nervous system, which includes the brain, the spinal cord, and the nerves of the eye, is what's affected by MS, and it causes many of the symptoms that you see on this slide here. And they're in different sizes and shapes. There can be anything from motor problems like difficulty walking, to sensory problems, feeling. Some people have numbness, some people have too much sensation or burning or extra sensations. Some people have spasms, some people have the MS hug, which doesn't feel like a hug. Hugs are usually pleasant, and that one is not. But there are many different symptoms, some of which are more visible and easy for people to understand and categorize as disability. But they're also what we call silent symptoms, such as bowel and bladder issues or cognitive changes that are more difficult for people to kind of grasp and understand as being caused by MS. So all of these things affect not only the individual living with MS, but also the people around you and the many relationships around you. So now we said, what is MS? Now, who gets MS? All right. Now, when I came out of training many moons ago, I got a lot of gray hair that you may not be able to see here while I am virtual. And so when we think about who gets MS, when I came out of training, we originally thought that MS was a disease of young white women of European descent. And although the highest prevalence, or where we see the most MS, is still in Eastern Europe, there's a lot of MS here in the United States. Nearly 1 million people in the United States have MS. And there are a couple of things that we're learning about the face of MS and what we think about MS. And one is that a lot of other people get MS than we previously thought. On the most recent statistics is there was a study published in 2023 looking at the incidence and prevalence of MS in Black and white individuals, as well as Hispanic individuals and Asian individuals in the US, out of one medical group, the Kaiser Permanente group. And what they found was that the occurrence of MS was pretty similar between Black and white people here in the States, even though Black people make up about 13% of the population. There are also some older studies that suggest risk may be higher in Black women, but certainly what we're finding is that more people get MS of different backgrounds than we previously thought. And the other thing that we're recognizing about MS is that most of the people who live in the US right now with MS are between the ages of 45 and 65. So when we talk about diagnosis, we often give that magic 20 to 40, but most people in the States now that have MS are in their 40s, 50s, and up into their 60s as well. So before we talk about MS specifically in the Black population, I always want to kind of open the conversation and talk a little bit about health disparities, because what we're really talking about is how health disparities affect certain groups of people versus others. This is a definition of health disparities from the Institute of Medicine, and this was a publication that they released a couple of years ago. And basically, a disparity means there's a difference in the quality of care that is not due to a person's healthcare needs or their preferences. So two people with MS go to the hospital with leg weakness and they don't get equal treatment even though they have the exact same symptoms. And the difficulty with health disparities is they can be caused by a variety of different things. In some cases, people may not have access to good providers, or what I would rather say is knowledgeable providers, so people who may be knowledgeable about their condition. Sometimes differences in insurance coverage affects the type of care you receive or where you receive care. And then certainly discrimination or bias on the part of healthcare professionals can be an issue. And I always like to say this can be a bias toward good or a bias toward something negative. I'll give an example. As a trainee, when I was training during my residency, there was a nice young lady who came in, or a young lady, I don't know if she was nice or not because I didn't know her. There was a young lady who came into the ER and she had symptoms that were very typical of drug intoxication. And I remember having a bit of an exchange with the other doctor working in the ER, because I was like, you need to do a drug test. And he was like, oh, she's a nice girl. She's she's in college. She's not doing drugs. And I was like, okay, but you need to do a test. And lo and behold, she was a nice girl in college who was doing drugs. Okay, so sometimes people judge a book by its cover, and that can result in inequities and unequal health care or improper care because we're making assumptions based on how someone looks. When we think about health disparities in the Black and Hispanic community, now these communities are often studied together because they are the largest minoritized groups here in the United States. This was a paper published by one of my good friends, Dr. Liliana Amescua, that looked at social determinants of health, which we'll talk about a little bit later, and health disparities. And what they found was that people with low socioeconomic status, that's SES, it impacts their health care. They found that overall, Black and Hispanic people with MS had higher morbidity, that severity of disease, as well as mortality at younger ages. Now, people typically do not pass away from their MS, but sometimes if disability is severe, that can occur, and that occurred more commonly in Black and Hispanic patients at younger ages. Also, we talk about clinical trials, which I'll not focus on today, but have talked about in previous discussions with MS Views and News and Stewart. Low representation and low enrollment of people of color in our clinical trials limits our ability to be able to generalize results. So ultimately, we want our studies to reflect the people that are actually being treated with whatever medication or whatever intervention. And when we don't have representative populations, it absolutely affects our ability to say, well, this applies to everyone. And then, of course, last but not least, systemic racism and discrimination and bias can impact a person's access to the healthcare system, as well as how they engage in the healthcare system. Now, I always like to point out that even though my work focuses primarily on MS in Black individuals, that's primarily the population that I serve here in Atlanta in the ATL, there are many underserved communities with MS that many of my colleagues are working diligently to try to address issues for. Certainly those who have low income affects their care. Rural populations, I know this is a passion for Stewart and MS Views and News, is to reach rural populations and make sure they're getting education and getting adequate care. Also, people who are older, and let me be very clear, even though our research studies for most of our MS trials end at the age of 55. 55 is not old, and neither is 65. But certainly our patients that are outside of the parameters of our studies, we don't have a lot of information on. And the same goes for our pediatric populations, those under 18 who are affected by MS. And basically, there are many other groups. I won't list everyone or go into everyone on this list here. And this is definitely not an exhaustive list, but gives you an idea that there are many populations that need attention that we need to better understand so that we can make sure everyone's getting the best care for their MS. Because when populations are underserved, as you can see on the right of the slide here, they may have higher mortality rates or death rates. They may have higher rates of disease or more severe disease, more medical costs, as well as lack of access to treatment and quality care. So this was a study that I had the honor to be co-author of with several of my colleagues, where we talked about MS in Black and Hispanic populations. And some of the things that we discussed were that the incidence and prevalence of MS are higher than we previously thought in these populations, which I talked about a little bit. We also talked about how social determinants of health can affect healthcare outcomes, that these are very complex issues that are difficult to unravel and difficult to untangle from race and ethnicity. And also that we need continued efforts to increase participation in clinical trials so that we can make sure that everyone has access to trials and know that they're an option, and also to make sure that our results are able to be generalized to the populations that we see in the real world. This was another study that we did focused on health disparities in Black women in pregnancy care related to MS. So this was a study with one of my colleagues, Dr. Raleigh Beauvais, who's out at UCSF, and we looked at close to 300 pregnancies, and you can see the breakdown there. 81 were Black women, 67 Hispanic, 146 white mothers. And what we found was that the Black mothers had a higher incidence of emergency C-sections as a way to deliver birth, while the Hispanic women had the highest rates of uncomplicated vaginal deliveries. And then babies born to women in the underrepresented groups, which would be Black and Hispanic, had lower birth weights and shorter breastfeeding duration, okay? So again, there's a lot of work that needs to be done. There's a lot of research focused on maternal health care outcomes, particularly in the Black population, that show there are many disparities, but certainly this is adding to what our knowledge is of MS and pregnancy in the Black population in the States. Now, when we think about what causes one group to have more severe outcomes versus another, there's always a question of what role do, let's say, genetics or biology play, right? And what role do these social determinants of health play? Social determinants of health are what we call the circumstances in which a person lives, grows, works, plays, gets old, etc. And there can be many social determinants that are influencing someone's healthcare outcomes. And there are some studies that suggest that social determinants of health, such as where you get healthcare, how you access the healthcare system, what type of insurance you have, etc. There are some studies that suggest that this can play even a larger role in your health outcomes than what medicine you take. There are a lot of my colleagues who do a lot of work in health equity and say that your healthcare is determined by your zip code. So where you live has a really huge factor, plays a really huge role in your healthcare outcomes. And I want to take a pause here because oftentimes when we talk about things like race and ethnicity, looking at MS or other diseases in Black and Hispanic populations, we have to make sure that we're clear that race is what we call a social construct. Basically, it's an arbitrary way of categorizing people. So there are some people who are of Asian background who have skin complexions that are darker than mine, but they're not Black or African American. And so we want to make sure that we understand that most of us, 99%, are genetically similar. Okay, but oftentimes, particularly in places like the US, when we're talking about race and we're talking about ethnicity, it's very hard to kind of untangle those from these social determinants of health and things like systemic racism and bias, etc. So we do use these categories to try to understand what's going on, but we also want to make sure we understand that we are more alike genetically and biologically than we are different. And so until we can get to the bottom of which of these issues is causing more severe outcomes, we do use these categories to better understand MS in populations. And also there may be cultural influences, there may be other things that are affecting healthcare outcomes aside from just, you know, a person's skin tone or background. This is some research that was done looking at social determinants of health and looking at different things to discuss outcomes in the Black population. So when we look at disparities in treatment, choosing disease-modifying therapies, one study suggested that only 30% of Black and African American people, as well as 20% of Hispanic patients, were started on high-efficacy therapy. That is pretty much the standard for MS treatment now, where we often start people on very effective therapies to try to get the MS under good control, versus 40% of white patients were started on these therapies. I think that this is important because, again, we have populations where it's been described that disease can be worse, right? Not necessarily across the board, and disease can be more severe, but they are less likely to be started on high efficacy therapy, not equal to their other counterparts. There are some studies suggesting that treatment response may be different. I think we have to be very careful because most of our studies, again, that include people of color, have very, very low enrollment of Black participants. So anywhere from 2 to 5% in most studies. And so we have to be careful, but certainly we need to understand how people may respond to treatments. And then, of course, when we think about comorbidities, that means additional diseases like high blood pressure, diabetes, high cholesterol, things that may affect overall outcomes for people with MS. These occur more frequently in people of color. And so it's something that we have to be aware of so that when we as researchers are doing our work, we're trying to make sure that we're understanding the impact of these conditions on MS and on our disease-modifying therapies. So what are some of the barriers to care in diverse populations? Certainly systemic racism is one, right? I list that one right at the top, right? Because it is an issue that needs to be addressed. There are bias and misdiagnoses, as I said, looking at the young woman and deciding that she couldn't be doing drugs when she was indeed doing drugs. And so sometimes we have our own biases based on our experiences, based on our interactions that we have to be aware of. Some people are misdiagnosed, and that can lead to delays in care. Sometimes there is lack of access to culturally competent care. So not just specialists, but specialists who are willing to understand where you're coming from, so to speak, and to try to make sure they're factoring in the things that are important to you in your healthcare decisions. Also, sometimes there are not support systems for people who are of minoritized backgrounds, particularly when we think about things like mental illness and the support needed to care for symptoms like depression and anxiety, etc. Distrust of the healthcare system can play a role, as well as lack of diverse providers, right? So again, I think the goal is we're not going to be able to make a completely diverse neurology society, or a completely diverse group of neurologists. That will take a lot of time. However, it is important to engage with whoever you are seeing and to make sure that they're trying to listen and understand what's going on with you. But these are just some of the barriers, but some of them I think we can work on, and I think there are some that definitely can be addressed. And how do we do it? So what should care look like, right? I think this is really important to say, okay, we got some issues, right? There's some things that definitely need to be addressed. There are definitely health disparities. We don't see this just in MS. We see this across many, many disease states. But what should good care look like? So this is a model that I think is really important. So good care should be where your healthcare team respects you and the things that you're saying, where you receive timely care as much as possible, where there's collaboration between your healthcare team, your neurologist, your other providers. There's communication. You're able to ask questions and get adequate answers to your questions, where they customize or try to personalize your treatment. Again, shared decision-making is extremely important. We won't go into a lot of detail about that today, but sitting down and having those conversations with your healthcare team to make sure you're getting the adequate care and that your team is on board and you know exactly what's going on and you know why you're doing what you're doing and what the goals are. And then, of course, cultural sensitivity, someone that is willing and open to listen and certainly is at least aware of their biases, because we all have biases. So how do we start? Set your goals, right? So I think this is really a key thing and something that I preach to my patients about all the time and talk about a lot when I give talks to our patient communities is that it's important for you to have goals for your treatment, to have goals for your doctor's visits. It's okay to have a list of questions and things that you would like to address. Sometimes I tell my patients, if you got 20 things, I may not be able to get to all 20 today, but I can get to the top 3 or 4 or top 5, and then we'll do another visit and we'll get to the next 5, okay? So setting those goals is really important because your healthcare team has their own agenda. When you go into that office, we know we need to talk about your treatment. We know we need to talk about your MRIs. We need to talk about this and that. So you need to have your goal set so that you can also address the things that you want, because there's a limited period of time and there are a lot of things that need to be covered. And so I think that it's really important to have some goals in mind before you go to that visit. If you need help, bring a care partner with you to help you set those goals. But those things are extremely important to make sure you're getting the most out of your care. And this is just a slide that kind of depicts what we're looking at when you're talking to your doctor about your disease modifying therapy. So we'll talk a little bit about lifestyle modification and how that's important. But when you are, talking about your disease modifying therapy and what your goals are with that, these are the things that should be taken into account with you and your healthcare provider before making a decision. So they take into account your MS, right? How active is it? How long have you had it? They take into account the type of treatment that should be discussed with you, the safety, the tolerability, side effects, how often you have to get monitored with lab work, etc. And then, of course, it's important to take into account your preferences. The best medicine is one that you can take, right? So one that you can be adherent to. We have to take into account your other conditions, if you have any other healthcare conditions, and how they may affect your medicines. And then, of course, personal factors, right? Are you traveling and moving around a lot? Do you have difficulty with hand movements and dexterity and may have difficulty doing something like an injection? All of those types of things should come together with that shared decision making to make sure that you and your team are choosing the best treatment for you. So other things that are important with developing your treatment plan, I put the same thing at the beginning and the end, which I think is important, and that's don't be afraid to ask questions. If you don't understand, don't be afraid to ask questions, all right? Shared decision making is key to having good outcomes. So putting all those factors together, making sure that you talk with your team if you're having issues or challenges, and always reassessing that plan at every visit is extremely important. Bringing a care partner with you, particularly to visits, I think can be very helpful. Number one, because they can be your extra brain to help you remember things or sometimes write things down so you can focus on the visit. Also, they may be able to see some issues that you may be having at home that maybe you're not aware of. I always call the care partners the truth tellers, right? So they're not necessarily telling on you, but sometimes their perspective can give us a little bit more of an idea of how you're doing outside of the office, so we can make sure that we're tailoring your treatment plan appropriately. Understanding your treatment plan to the best of your ability, I think, is extremely important. We don't expect you to have a medical school degree unless you have one already, but we certainly want to make sure that you understand what our goals are and what we're trying to accomplish. Making sure you discuss the next steps with your team. When's your next MRI? When's your next assessment, etc. And then knowing who to contact if you're having issues in between visits. So all of these things I think are key to making sure you're getting the most out of your visits and making sure that you're getting the most out of your healthcare team. Now, let's talk a little bit about lifestyle modification. I'm going to talk just for a few more minutes because I think this is really important. I think that the medical community is really kind of behind the 8 ball with lifestyle modification in terms of we give kind of very broad, eat right, exercise. But, we need to be working on this a lot more to make sure that our patients and the people who are living with MS know that lifestyle can really play a large role in how you do. I always say medicine plays a part and you play a part, but the medicine does not get rid of the part that you play in your own health care. So lifestyle modification is extremely important, right? And there are now studies that are coming out to show that these things really can make a difference in how you feel overall, and in some cases on different factors related to your MS. So I'll start with diet. diet. I'm not going to tell you there's not a magic diet for MS, okay? But there are ways that you can work with your healthcare team. You can see a dietitian, you can see a nutritionist. There are other integrative medicine doctors that do a lot of work with diet and, let's say, elimination diets, other things to help you to feel your best. I think the bottom line with many of the diets that are out there are that you're supposed to eat more fresh foods and less processed foods, and everybody's kind of got their little spin on it. So there is not a magic one that works for everyone. I personally have had patients that have done well on probably every single diet you can imagine, but the one that you can stick with is the one that's most important. And it doesn't have to be the most extreme diet where you eliminate everything, but certainly some people find when they eliminate certain foods like carbohydrates or sugars, for some people it's gluten if they have an intolerance, that it can make a difference in how they feel on a day-to-day basis. So examining that, I think, is one of the best things that you can do for yourself. Another important piece is stress reduction. So the mind body, I listen to a lot of Deepak Chopra, if you're familiar with him. The mind body are one, right? So the mind and the body are very connected. And so when we are in more stressful situations, it can absolutely affect any chronic condition you have, including multiple sclerosis. So I counsel my patients a lot about stress reduction. You see this lady meditating right here. Sometimes this is me after a long day at work, or sometimes after a long night with my kids, right? And so stress reduction is extremely important. I talk to people a lot about mindfulness practices. Meditation can be very helpful, and there are some studies that are coming out about meditation for chronic conditions, including MS, and how it may be helpful. And then also doing things you enjoy, right? So that are not harmful to you. I had a patient today that said she liked to eat pound cake. And I was like, well, pound cake can be a little bit of a stress reduction, but we can't do that on a everyday basis. So again, finding things, outlets for stress, as well as learning how to manage it. Sometimes it also includes things like seeing a counselor, right? Mental health professionals, right? Sometimes a lot of what we call stress is actually depression and anxiety that needs to be treated. So looking at this aspect is extremely important because it can affect how you feel on a day-to-day basis with MS. All right, and then the last piece of lifestyle modification, certainly this is, again, not an exhaustive list, but things that I like to touch on, when we're talking about empowerment and we're talking about what you can do to help yourself. Exercise is extremely important. There are multiple studies that have come out showing that exercise impacts overall health outcomes. And when we think about multiple sclerosis, we think about activities that are brain healthy activities. And often the same activities that are considered kind of heart healthy activities, diet, exercise, stress reduction, right, can also be brain healthy activities. And what we're trying to accomplish with brain health is that we want to try to build up what we call your neurologic reserve. So you have a reserve that kind of helps shield you from injury, right? So if you have an injury from your MS, oftentimes your brain may be able to compensate, which is why you don't necessarily have a symptom from every lesion that you have. But over time, as we age and as, if we don't engage in these brain healthy behaviors, that reserve continues to decrease. Now it's going to decrease, but it may decrease faster if we haven't been doing things to build it up. So exercise is a big one that helps not only with brain health, but also can help with many, many symptoms of MS, ranging from spasticity to constipation to mood. Exercise has many benefits. And I think it's really about finding the right type of exercise for you, recognizing that you don't necessarily have to put on your, exercise outfit and go to the gym and run for an hour and do aerobics for an hour and swim for an hour. It really can be something simple. There are exercises you can do at home. There are exercises you can do without equipment. So I think it's important to find the right thing for you, but to get some movement in, because that really makes a difference, not just in how you feel on a day-to-day basis, but also can make a difference in the brain, in the actual brain tissue and brain volume. All right, so in summary, what can you do to take control of your health? So we talked a little bit about health disparities. We talked about how certainly there are, a great deal of data suggesting that there may be worse outcomes in some groups, but that there are things you can do to help yourself. Making sure you are an empowered patient, that you're engaging with your healthcare team, that you are aware of your plan. And also, one thing I didn't mention was that if you're not getting the care you need, get another opinion, right? And that if you can see an MS specialist, try to see a MS specialist at least once during your journey with MS. So other things you can do to take control of your health: make sure you're learning about your diagnosis. You're all at this program, so I'm preaching to the choir. Understand your treatment and stick to it. Those brain healthy behaviors such as diet and exercise and stress reduction can really make a difference in outcome. Making sure you're talking to your team and not afraid to ask questions. Of course, finding your support system, whether that is through your natural family or your family that you've created from friends over time, and then not being afraid to ask for help when you need it. And of course, I think one of the most important things I can always say is that remember that you are your own best advocate. All right, and so this is how you find me. I am the Nerdy Neurologist on all social media platforms. And I thank you so much, MS Views and News and Stewart, for giving me this opportunity to talk about a topic that's really important to me. And I always end every slide with the same, every talk with the same slide. All I need is peace, love, and a freaking cure for multiple sclerosis. Thank you guys so much for your time and attention. And Stewart, I need you. Come back up. It's time for questions.
Thank you. I have a couple of questions here. First being that person writes, if patients are not receiving high efficacy drugs, those of color and or those in rural and undisturbed areas, who's responsible for that and what can be done to change it?
Yeah, so as I said, the paradigm or the way that we think about treating MS has changed over time. I didn't realize I still had my headphones on. Sorry, guys. It's changed over time. So we do try to start high efficacy therapies early as much as possible. However, there are some people that do well on therapies that we don't consider high efficacy. So if someone comes into the office and they're on a lower efficacy medicine and they're doing well and that's treating their MS, then I don't mess with the mojo, right? Because everybody's MS is different and everybody's body works a little bit differently. However, if you're on a treatment and you feel like you're getting worse or your MRIs are getting worse, that's a really good reason to go back to your doctor and revisit. And again, if you have questions or concerns about treatment, it never hurts to seek another opinion. Now, you may see someone else and they say, hey, it looks like you're doing good. Keep up the good work. But you may see someone else and they may be like, I think we can do a little bit better. So that would always be a time to consider a second opinion.
Great, thank you. So you mentioned something about MRI. So how often are you saying that people should get an MRI?
Yeah, so there are guidelines by the Consortium of MS Centers about how often we should get MRIs. Particularly in the first 5 years of disease, we recommend MRIs on a yearly basis. If we're in a period of transition where you transition to a new treatment, usually an MRI is done within a year of you starting a new treatment, and usually once a year for several years after. If I have someone who has MS and they have been on treatment for many years, and they're very stable, and we may do MRIs every 2 years or every 18 months, so at least once a year very early on. Some people move that out to 18 months, or some people do that without contrast because there is sometimes concern about contrast buildup in the brain.
Great, thank you. Another person writes, what type of advice would you give for working while you have MS? The types of jobs for people with MS.
Yeah, so the bottom line is, honestly, the sky's the limit. So I have patients who are doctors, lawyers, consultants, executives. It really all depends on how their MS is doing. Stewart is the mastermind behind this whole organization and travels all over the US and does programs. So it really depends on what type of symptoms you have and what type of issues you do or don't have. But there's not really a specific job for people with MS because I have people with MS who do literally everything.
Oh my gosh, you just told people I have MS.
Oh, I'm so sorry. Cat's out of the bag.
Oh my gosh, it hasn't been said before, right? Okay,
Yeah.
thank you for that. Next, person writes, can you talk about the Epstein-Barr research?
Yeah, so I just recently went to a conference, and there's a lot of work focusing on Epstein-Barr. So Epstein-Barr is a virus that typically, when we think of a syndrome, it causes mono. So when I was in high school, I don't know about you, Stu, we used to call it the kissing disease. So somebody was kissing and then they were missing from school for a couple of weeks, right, or sometimes a month. So mono is a typical syndrome that's caused by Epstein-Barr, but most people have Epstein-Barr that didn't have mono. So there were studies in the past couple years that showed us that you have to have Epstein-Barr virus to get MS. The difficulty is that like 99% of the world population has Epstein-Barr virus. So there's some work looking at things like, let's say, a vaccine to maybe see if preventing it could affect MS. But I think we're very early on in kind of what that means, just because so many people have it. And how do you really kind of figure out what is that secret key that's unlocking it for people with MS versus pretty much the rest of the population that doesn't have MS?
Okay, thank you.
Mhm.
People want to know, a person wants to know, if it was so easy for an mRNA vaccine for COVID, why is it taking so long for MS, for a drug to be found that will be the cure? And is it possible that an mRNA medication will be available for those with MS in the future?
Yeah, so that's an excellent question. Now, one issue, or the main issue, is that there is not a target that's been identified with MS. So when we think about most other autoimmune diseases, including NMOSD, which is a disease that used to be included as a part of MS, but now we know it's a completely separate disease, is that we have an antibody. We know what the target is. So when someone has rheumatoid arthritis, we can check a rheumatoid factor. If they have lupus, we can check an ANA. So with COVID, we know what the target is. It's a virus, right? And so the difficulty with MS is that we've got these millions of people with MS, but we don't have one target or one test that we can test everybody for to say this is 100% MS. So it's difficult to find a cure when you don't know what a target is. And again, an mRNA vaccine can be helpful usually for some type of what we call pathogen, like a virus, but we don't currently think of MS as a virus, right? The other difficulty is that we do have different genes that have been identified that are associated with increased risk. But again, it's not like sickle cell where we say you got a bad gene we need to fix. There are over 200 different genes associated with MS in different combinations. So the biggest difficulty right now is that we don't have a target and we don't have a specific gene or cluster of genes that we can say, okay, well, if we fix these genes right here, we can fix the MS.
Thank you. So you said that NMOSD, which is, for those that don't know, that's neuromyelitis optica spectrum disorder. And yes, it is a rare disease, and it is a disease that MS Views and News started providing educational programs for as well. And so there's a lot of people out there that don't even know that they have it, right? So if they were able to come up with an antibody for that, how did that happen when it was once thought to be a derivative of MS, and now they have an antibody for that? So isn't there like one gene off from MS that's causing this whole thing?
I wish. Listen, I would be happy to cure everybody and go home and sip lemonade in the shade and play with my kids. You know what I mean?
Sure.
And so, again, NMOSD is a very small number of people, but is very specific, right? So we know that primarily the eyes and the spinal cord are affected, versus MS, you also have the brain affected. So the fact that you kind of have a small group of people who have this disease, you can kind of pick them apart, not pick them apart, that's not an appropriate term, but you can kind of look at them in depth and see kind of what is the underlying factor. But I think the difficulty with MS is, again, there are just so many different genes, there's so many different presentations. Everybody is a little bit different, but many people have been searching to see if there's an antibody. We just haven't identified one yet.
Gotcha. All right, I got a couple more questions, and before I ask them, I'm going to tell everybody, if you have a question, don't wait for somebody else that could possibly be asking your question, because it may not happen. And then, you know, it's going to happen like when you go to the doctor and the door closes. Well, it's too late to ask your question. So if you have something to ask, type it, okay, and let us ask the question. All right, next one comes from a person. Say that again.
I said, don't be shy.
Don't be shy. Exactly. Be like me. Don't be shy. All right. This next question comes from a person that, before I ask you what she wants to know, I'm going to let this person know that if you're able to do what you want to do, I would like you to let me know and let us help you broadcast what you want to do. The question is, what kind of advice would you give for someone who is starting a Black MS support group?
Yeah, we need more of them, right?
Need tons of that.
Absolutely. So the advice I would give is to look for resources, right? So there's some of our national organizations that actually provide resources and kind of like a guidebook on how to start a support group. So I think definitely, I believe NMSS has one, as well as MSAA, just on how to start a support group. So that would be great. And then I think, kind of figuring out who in your area would be interested. Sometimes, now there are not as many in-person programs as there used to be, but that used to be a great way for you to meet other people who are part of the MS community. But certainly social media can be a way to reach out, or your doctor's office. But the advice that I would give is, to find your tribe, to try to make it uplifting in some way. I have many people who may have themes for their meetings, etc. But know that, you reach out and the people that need you will find you.
So again, I will say for this person, if you want to send a message to me, we will help broadcast this in your state or surrounding areas as well. I don't know if you want to do it virtually or in person, but yes, we will help you get the word out about this.
Absolutely.
And if you don't know how to find me, you haven't been around long enough. Okay. But you're getting emails from me, so that's how you email back. I mean, all right, just do it that way. She already responded that it is in person, and thank you so much. And yes, get the information to us, and let us help you promote this. Okay.
Absolutely.
All right. Next, person wants to know how they get prescription assistance.
So I would talk to your doctor's office. There is assistance for all of our disease modifying therapies except for the biosimilars. So our newer biosimilar drugs are not technically called generics, do not generally have the same support as our trade name drugs, but talk to your doctor because if there's a change in insurance, they can get assistance. Now, assistance for other medications like symptomatic medications can be difficult. So we encourage you to talk to your local pharmacy. They have a Good RX, which sometimes gives you discount. I've had some patients who've been able to get actually some of their disease modifying therapies through Mark Cuban's pharmacy. He actually has some disease modifying therapies for pretty cheap. So, you can look at those different resources and see if your drugs are listed there, as well as the $4 list for Walmart. I keep it on deck in all my exam rooms, and see if there are any providers of your drugs that decrease cost, or if there are any coupons online for your medications outside of your disease modifying therapy.
Great, thanks. Inexpensive, not cheap.
Inexpensive, yeah, absolutely. Because to me, cheap is free. Free is my favorite kind,
Right.
but less expensive. Less expensive.
Great. All right, next one. What new studies did you learn about while you were recently at the conference ACTRIMS?
Yeah, who knew I was at ACTRIMS? That sounds like a oh, that's your question.
That's me.
So there was some interesting data. There was, unfortunately, some very disappointing data on one therapy that we were hoping would have positive results. There's a new class of therapies we've been very excited about called the BTK inhibitors. And we were really excited about them, or still are excited, because all of them haven't reported results. But we were really excited about this group because they're one of the first drugs that may actually be able to cross over into the brain, into the CNS, and treat inflammation in the brain. Most of our other drugs treat inflammation in the blood, right? Which is why we give them by mouth and give them an IV, etc. So unfortunately, it had some very disappointing results where it did not meet any of the endpoints of the study, so it didn't have an effect on relapses, but it was compared to another drug on the market. There are several other drugs in this class. Some of them are being tested for progressive MS, which many of us are very excited about because we still don't have great treatments for progression. And so we'll see the results of some of these other studies as they come out. Other than that, you know, a lot of the conference was about reporting on some of the other studies like safety, that nothing new had happened in terms of safety, et cetera, et cetera. But I think that was the big one that came out of that conference, was the drug that had the negative study, unfortunately.
Great, got it. Thank you very much for that. Next, a person in your hometown as asking, do you have any tips for those of us applying for or awaiting a decision for disability retirement benefits? I've had MS for 36 years and just stopped working 2 years ago, still waiting a decision.
Yeah, be patient and get an attorney. I mean, the people that often do the best do have an attorney. It can be very difficult to navigate. There's a lot of work that needs to be done. I have many patients who, even though they deserve it, may get denied the first time. So I think that patience is the key. And then if you can afford or get an attorney, often that helps to smooth out the process. Go ahead, Stuart.
You don't have to pay for an attorney. So a
Yeah.
disability attorney, there's no charge.
Okay, great.
And if anybody needs one, we have one that's part of our organization. But to find any Social Security disability attorney does not cost you anything except your time. All right.
Yeah.
And you should go see one of these people simply because they will help speed up the process for you. And they get a percentage from what the government gives you, not from what you get. Okay.
Absolutely. Get an attorney and be patient.
So if you need to know attorneys, give me a holler, or just open up your Google and search Social Security disability attorney in your area. Okay. All right, glad I could help out. Next, person writes, switching from Ocrevus to Mavenclad, are there any tips? My disease has progressed rapidly and a seizure. Also, I can't read it. Something starting a group. I don't know what it is. Okay, putting on hold for healing.
Okay.
Also interested in starting a group. There we go. I got it now.
Okay, so I cannot give specific medical advice. That sounds very specific. If someone is transitioning from one treatment to another, it definitely needs to be under the guidance of your healthcare provider. I will say that we used to do a lot of very long, what we call washouts between therapies. Like we used to really wait the whole time until the medicine was out of the system. But we've learned over time that people start to have problems. So we don't usually wait. Like for instance, Ocrevus technically lasts 6 months. Most of the time we wouldn't wait 6 whole months to start your treatment. So, you know, again, trusting the process, you know, making sure you're communicating with your healthcare provider. If you're having any issues before you're supposed to start therapy, to make sure they address that, or maybe adjust that window of when you start your new therapy.
Okay, thank you. So it was so nice that I told people that they have to type their questions, because now they're writing questions like this long. So it's fun, right? If someone had delusions before, after the onset of MS, do you have any advice to deal with situations when stress arises and how to make people understand? I can't tell what is real or not real if these situations arise. Sorry for the unclarity, not sure how to talk about this, but we could use help and advice.
Yeah, so again, that sounds really specific. Delusions are not something that are considered a common symptom of multiple sclerosis. The most common psychiatric symptoms we see are depression and anxiety. And sometimes people may have bipolar, which is, a form of depression, but we don't typically see delusions. Certainly that is something that will need to be addressed by a psychiatrist. And oftentimes with my MS patients who do have other psychiatric conditions, we do co-manage them with psychiatrists. So it would definitely be something important to manage with psychiatry, as well as your neurologist being in the loop and making sure that you're not, for some people, medications can sometimes affect their mental state, et cetera. So making sure that your doctor is looking at all those medications can make a difference as well.
Thank you. What about those that are using medications like Aricept?
Mm-hmm. Yeah, so it's interesting. We have some things that kind of make an emergence and then they fall out of favor, and then they come back and then they fall away. So for instance, I remember back in my training, everybody was really excited about cholesterol drugs. Cholesterol drugs helped MS, and then they stopped, and now some people give them. And so we used to give out a lot of Aricept, which is the medicine that we use for dementia, for people with MS, and didn't really see a whole lot of effect, and then it kind of fell out, and now some people are using it again. Again, all of these things are individual basis for each person. It's important to recognize that some medications, many of the ways that we find medications work is that, for instance, we use it for something else and we find that it works for something else. So for instance, gabapentin, one of the most commonly prescribed drugs we use for numbness and tingling, was a seizure drug, right? It didn't treat the seizures that good, but it darn sure helped the numbness and tingling, so there's not really a protocol for using that with MS, but each individual neurologist and healthcare specialist, you can talk to your doctor to see if it may be an option. But really the research just hasn't been exciting concerning the use of drugs for MS cognitive problems.
Okay, thank you. There's a question coming from the Washington, D.C., Maryland area, and because that I'm seeing that, I wanted to just say that next month we're doing a program in that region with Dr. Heidi Creighton for our Compass MS Care Series, exactly. And also getting a spot to speak is a person who is the founder of an organization for people of color with multiple sclerosis. And so she will be speaking also at this program. And so I just wanted to give her, I'm not going to say names or anything else. You all will hear more about it when we start making, well, we already started making announcements about it, but our virtual announcements you'll be able to see through our website as well. All right, so now I will ask her question. Why do most clinical trials not accept participants older than 55 years old?
Yeah, it's an excellent question, because 55 is not old. No, I'm just messing. But so
she didn't say that. She said older than 55, not that they're old.
I just wanted to clarify that 55 is not old. So one of the reasons is when someone is doing a clinical trial, they want to try to get the best data possible so that we know that, that drug has that effect. So when we're looking at age, oftentimes as we age, we develop other issues. We may develop arthritis, we may develop high blood pressure, diabetes, etc., other conditions. And so it can become difficult to distinguish what's the MS and what's aging, right? And that's a problem I still have with a lot of my patients. It's like, okay, my knee is tight. Is it spasticity from my MS or do I have arthritis? And so that's the difficulty. Now, there is a lot of work focused on increasing that age for our clinical trials. And there's some, phase 4 trials that don't have age limits, but that's really the main issue, is trying to distinguish what may be signs of normal aging versus what may be symptoms from MS when we're trying to categorize like a relapse and things like that.
Okay, thank you. A person is asking for one of us to repeat the information you spoke about a Social Security disability attorney, what you said about the cost. Ooh, that would be me. All right. So it doesn't cost you anything to use a Social Security disability attorney. It costs, they get their payment if they win. There's no cost if you lose at all to the attorney. And if they win your case, they get a percentage from the U.S. government based on what you are awarded. All right. And you just get what you are awarded, and that's it. And then you got to figure out the rest and go on with your life. Okay. All right, but yes, you could find Social Security disabilities attorneys online, and you could just look them up, or you can send an email to me, and I will try to help you out. The person that works with us is a nationally. She takes cases all across the United States, so I can point you into that direction if you want to send me an email. Okay, that's it. Glad I could help. Okay, that's what we do. That's what MSVs and News is all about, everybody, is we provide resources and information, okay?
Absolutely.
So
absolutely.
That's what it is.
You're doing a fantastic job.
Thank you very much. And Doc, we are out of questions, believe it or not. We are out of questions. You get to get going to your kids early, and I want to thank you for everything. Thank you for being online tonight. And again, this was an MS Views and News program, and we look forward to seeing you all online for our next programs. Just go to our website and check it out. Thank you. Have a great night.
Thanks, everyone. Have a great night.